Well, let's think about Kit and what role the role of hope plays in Kit's or Frank's illness. First, you hope that it's not true. You hope that it will go away. You'll hope that the treatment will work. You hope that you'll be comfortable. Hope you'll be able to complete important tasks with family and friends and forgiveness and love issues. To hope for a good death. To hope the family will prosper after death. All the while, hope is sustained, but the object of hope changes over the course of years or decades. So we can summarize our advice for Kit as hope for the best, but prepare for the worst. We want to do both. We want Kit to live as well as possible, based in the reality of what medical science can give, and making sure we pay attention to the relief of her suffering. After Kit's operation, she had no cancer, but she had terrible chest pain, right in the area where the incision was made for her chest operation. This is postoperative neuropathy. Some of you watching this are likely to have this. It can be a terribly debilitating condition, and yet the cancer is gone. You need to know that this can be managed. It takes often aggressive management with opioids like morphine and adjuvant drugs like gabapentin or diazepam. There are many medications, when combined, give relief from this. For Kit, this is what the palliative medicine component of her cancer care was, to make sure that her pain control was well managed so she could go on and take that new job. But what about the emotional dimension of Kit's illness? Her husband. His reaction was, oh my God, I might lose my wife. He was the one that needed the most emotional support, and many of you who are married will recognize this. But for Kit, one of the biggest challenges for her was the spiritual dimension. Have I led a good life? Why did I have this cancer? Why did I get this cancer? Is this a judgment from God? Every patient who has cancer wrestles with these kinds of questions, and the palliative care is part of making sure that that is built into the cancer care across the continuum. A year later, the cancer did come back in Kit's lymph nodes. She had chemotherapy. It worked some. She had radiotherapy. It worked some. It certainly helped her live longer. We need to contrast Kit's hopefulness with what is a wish, which I would define a wish as something that you long for but is unlikely to happen. Kit, of course, wished that the cancer would go away. The chances of that were very small. That shouldn't get in the way of making sure that all of these other issues of Kit's illness are taken care of. So the chemotherapy made her partially better. The radiotherapy made her partially better. But most important, Kit was able to continue to work full-time with good symptom control and enough emotional support for her and her husband that they could continue on in a productive life. At the end of a rather long course of illness, Kit was referred for hospice care, but it was smooth and continuous the rest of her cancer care. If you notice in this photograph at the left here, this is Kit reading with her daughter who lived in India and had time to spend with her. Kit needed exquisite attention to her symptom control to be able to appreciate this. For many of you who have grandchildren, do you recognize this kind of a photograph? Sitting on the sofa with grandparents, enjoying them? This is a part of cancer care. It means that the attention to symptom control and emotional and spiritual and social support needs to be exquisite. And I think particularly her primary relationship with her husband, this photograph was taken 2 days before Kit died. You need to have the vision that this is possible, but it is with the best possible palliative care integrated into cancer care. So I would say that clinical palliative care, what you should expect is wherever you're getting your cancer care, that there are consultation services. There are experts available to help your oncologist, others with these issues related to palliative care. There is a need for dedicated inpatient care in hospitals and in specialty units. Of course, hospice care is there, but it's just a part of this continuum. And we need the ambulatory clinics and the home health agencies, and we cannot forget the skilled nursing facilities. It's available in every place in the spectrum. All right, well, if that's the evolution, what is the physician role in this? This is a photograph of the first fellow at the Institute for Palliative Medicine studying to be a specialist in palliative medicine. This is Dr. Gil Nacco. Palliative medicine, the physician component of palliative care, is a best practice at a generalist level. Every doctor, and particularly every oncologist, every surgeon, every nurse, every social worker, every chaplain needs basic approaches to palliative care as part of his or her skill set. But then at the specialist level is an interdisciplinary, comprehensive practice approach for patients and families, particularly when the standard approaches don't work. This graph shows the number of physicians specializing in hospice and palliative medicine growing in the United States. You can see this is extending over 10 years and continues now. This is very good news. This is about bringing the relief of suffering that we know how to do and making it practically available. One of the most recent developments in 2006 is the formal recognition of this specialty. What I've listed on this slide here, these are all the specialties that sponsor hospice and palliative medicine, meaning that a physician in any of these areas can become a specialist in this field. But that probably comes alive more when you actually see a photograph. This is our entering class of physicians. You notice they're bright, they want to help, they want to apply the science of the relief of comfort, relief of suffering, providing comfort, and they will work as consultants throughout this country. There's a national document, Improving Palliative Care for Cancer by the Institute of Medicine in Washington, laying out that every cancer center should play a central role in advancing palliative care research and clinical practice. You as patients need to expect this as part of your comprehensive cancer care. Now this, I've included a cartoon from the New Yorker. Here's a physician across his desk from a patient, and he says, "There's no easy way I can tell you this, so I'm sending you to someone who can." I think this cartoonist probably wrote this in a pejorative way, thinking, doctor, you need to be able to have the tough conversations with your patients. But if we're honest, if you're honest, if I'm honest with what I see, there are many physicians who are uncomfortable with this. It turns out that palliative medicine clinicians who are skilled in this can help give patients the information they need in order to set goals and make sure that care matches those goals. This is data done by the National Association, the American Society for Clinical Oncology, which represents medical oncologists, surgical oncologists, pediatric oncologists, radiation oncologists, and they were surveyed about their knowledge about palliative care. 90% of them said they learned by trial and error. Now, would you have confidence if your surgeon who was about to do your appendectomy said he learned how to do appendectomies by trial and error? No, you wouldn't. If you notice, 73% they learned from colleagues and role models. Now, I don't want to interpret this as bashing oncologists. Oncologists had the courage to do this actual study. I think this is true no matter what the specialty. And we shouldn't be embarrassed about it. The science, the new approach to being able to relieve suffering and improve quality of life is new. Most of the people in practice were not exposed to this.